Good morning. Welcome back to the Global Neuroscience Institute Grand Round series. And now it is my great pleasure to introduce Dr. Martina Vendrame. Dr. Vendrame obtained her medical degree from the University of Padua in Italy. She completed a PhD in neuroscience at the University of South Florida and neurology residency at Temple University. She trained in clinical neurophysiology at Brigham and Women's Hospital. Dr. Vendrame holds double board certifications in neurology and sleep medicine. Throughout her career, Dr. Vendrame has been actively involved in various clinical research projects, primarily focusing on investigating the impact of sleep disorders on patients with epilepsy. Her contributions to the field are reflected in her impressive academic record, including 49 peer-reviewed publications, 6 book chapters, and participation in over 50 scientific meetings and presentations. Currently, Dr. Vendrame serves as a director of the sleep neurology program at the Fleming Lehigh Valley Neuroscience Institute, where she is also the associate director of Lehigh Valley Clinical Neurophysiology Fellowship. Dr. Vendrame will be talking today about sleep and epilepsy. Dr. Vendrame, good morning.
Good morning. Hi. Good morning, everyone, and thank you for having me. Okay, so today we will be talking about sleep disorders and epilepsy. So the first part of the lecture will be about how to recognize epileptic events versus non-epileptic events occurring during sleep. And during the second part of the lecture, we will talk about how to identify and manage sleep disorders that are comorbid with epilepsy. So there are 4 types of epilepsies and seizures that are typically related to sleep. So sleep-related hypermotor epilepsy used to be called frontal lobe epilepsy, juvenile myoclonic epilepsy, JME, the famous Rolandic epilepsy called Beck's and now called SAD-limited epilepsy with central temporal spikes, which is a pediatric epilepsy, and the Londo-Kleffer syndrome with EICS and continuous spiking wave discharge during sleep, which is a classic pediatric syndrome. So I'll be talking about the first 3, and I will not be focused on the last one, purely because it's a specific, relatively rare pediatric epilepsy. But just to tell you what it is, these are kids that present with the epileptic aphasia at about age 6 or later. And they have primarily seizures during the EEG during sleep, while most likely they don't have epileptic abnormality during the daytime. Anyhow, so we'll start with the frontal lobe epilepsy. Again, now called sleep-related hypermotor epilepsy. So the interesting fact about this type of seizures is that they were always thought to be a dystonia initially, and this I'm talking about probably the first part until the 50s probably. And in the International Classification of Sleep Disorders, these seizures were considered a parasomnia. So in sleep we call parasomnia any abnormal behavior which is out of sleep or during the transition between sleep and wakefulness. And this is exactly how this seizure present. So then from a parasomnia, the sleep medicine was a parasomnia, was considered a movement disorder. Mostly because prominently during the seizure, this patient have dystonia, usually unilateral. So it was always classified as a movement disorder. And then later, when EEG technology developed, it was really understood that these patients had seizures and from the frontal lobe. Seizure on EEG can actually be seen in the frontal leads, but also from the temporal lobe. So semiologically, they're called frontal lobe seizures because they have a peculiar semiology. A lot of time, these seizures start from the temporal lobe. And then later, because the understanding now is that these seizures are mostly related to sleep and not to the fact that they happen at night, we have even changed the name of this. So we should not talk about nocturnal seizure anymore, but we should talk about sleep-related seizure. And the good thing to know here is that when someone presents with seizure they say during the night, we should always ask if they're out of sleep or during wakefulness. And I'll show you later some examples. So semiology-wise, sleep-related seizures, so frontal lobe seizures, they have a peculiar semiology. Number one, they can just present with brief dystonic posturing. And I'm talking about a few seconds of posturing. They can also evolve to more complex behavior with automatism, which could be very complex with bicycling and all that. And then people can also walk, they can jump, and they can scream. So you can think about also why, you can understand why these were thought to be a parasomnia and also to be just a simple movement disorder. So almost all seizures from the frontal lobe, they occur out of stage 2 sleep, so during sleep, except those from the supplementary motor area, which are classically those that present with automatism, and they may occur during wakefulness. This for us is very important because you may have a patient that presents with nocturnal seizures because they tell you, oh, they happen at night. And if you take a careful history, if you have a video, you can see that the patient is actually awake. And a lot of times they can remember the seizure. And during the seizure, they engage in this automatic behavior like bicycling, which may really not thought to be a seizure, especially because it's during wakefulness. Very importantly, they tend to occur in clusters, these seizures. And cluster, we mean there could be several seizures per night and also several seizures per month. There is a positive family history commonly. There is a genetic form, the autosomal dominant nocturnal frontal lobe epilepsy. The genes are very well known, and usually the family history is pretty obvious, is present. So this is a video of a patient who, let's say, is sleeping, and it seems like it looks like he's waking up, is maybe sitting up. He actually has a posture on the right arm, and then you can see it on the left arm. Is bend his left arm, and is turning to his right side. So his torso goes to the left side, and his head is moving toward the left. In a bit, you will see his behavior get also a little bit more complex. Look, it's turning over now. It's turning to the other side, and he's trying to reach above himself in extending his right arm. And he's also vocalizing. The audio is probably not perfect. And now he's also lifting his right arm. I'm sorry. So what is this? This is a classic seizure of sleep-related hypermotor epilepsy or nocturnal frontal lobe epilepsy. This is EEG when this happened. So this is in stage 2 because you can see these are sleep spindles. And the seizure starts, probably the seizure onset is about here. So there's anterior temporal, left anterior temporal, mid-temporal, then the seizure evolves over here. You can see the seizure spread to the frontal leads. This is his seizure evolution, then remains sustained, and then resolves. And toward the end of the seizure, you can see still activity mostly over the left temporal. So this guy actually had genetic testing, and even if you think electrographically, it could be temporal lobe seizures. Semiologically, is frontal lobe, as well as genetically, was genetically established. It's actually important to know that there is a genetic cause of these seizures, because the genetic forms of frontal lobe seizures, they respond very well to zonogram. So zonisamide is the best medication for these patients. So again, so it may be misdiagnosed with a parasomnia. And again, the funny thing, it used to be thought it was a parasomnia because clinically it is a parasomnia. But in children, it needs to be differentiated from night terrors and confusional arousals. And in adults, it needs to be differentiated from REM behavior disorder. And I will show you in a moment how REM behavior disorder presents and how we can distinguish between REM behavior disorder and frontal lobe seizures. Very important, only 1/3 of these patients have a positive routine EEG. So in the end, the LTM EEG remains the best test for the diagnosis. So this is a 19-year-old woman presenting with new onset nocturnal tonic seizure. I said nocturnal on purpose because by history, we only know that her seizures are out of during the night. So, and this, let's say you see her in the morning, and she does this. So this is myoclonic jerks. So these are myoclonics, and these are myoclonic seizures. So this was her EEG. So these are classic EEG of GNI, which basically shows about 4 to 5 hertz spike and wave, generalized spike and waves. For this type of epilepsy seizures, the important things to know is that the hallmark myoclonic jerks may not always be present. It can also be overlooked, so you need to ask about them. They can have, they may not have, but they most likely will have history of tonic-clonic seizure. They may occur completely independently from the myoclonic jerks. And the important thing here is that these seizures occur out of wakefulness. So if you can take a good history, this patient can tell you that they were awake when they had a seizure. And the reason how they can tell you that, they can tell you that they remember right before the seizure started. So you can ask them, were you awake? What do you remember? Do you remember waking up and doing something? And then you don't remember anything else. So this is one of the key in differentiated this type of seizure, for example, frontal lobe seizure from GNI. They can have stirring spells. When they're during the daytime, they can mimic daytime sleep attacks, mostly this in young children. And there is a genetic component, so taking a history is important. It's not autosomic dominant, so the genetic component is not as strong as the sleep-related hypermotor epilepsy. So this instead is a 9-year-old boy with nocturnal tonic-clonic seizures. He presents with drooling of his face and pulling toward one side. So this is his EEG. And the EEG shows spikes, sharp spikes over this is the left mid-temporal, and this is you would think is the left central. So the classic central temporal spikes. And this is the an EEG, which is a pathognomonic of so-called Rolandic epilepsy or epilepsy central temporal spike, now called self-limited epilepsy. EEG for this type of epilepsy is fundamental. EEG is likely to be positive, and even if you obtain the EEG during the daytime, which is so a simple EEG can actually make the diagnosis in these cases. So presenting kids about the age between 3 to 13, and usually they go away. So the important thing here is that they have a benign nature, these seizures, this type of epilepsy. So it is also the most common focal epilepsy of children. So it's important to always suspect it especially when you see a younger patient. So you can have it in a 13-year-old. Sometimes we see 13-year-olds in adult clinic that can present with the nocturnal seizures. So 2/3 of these patients, they report seizure out of sleep. Obviously, these are kids, so it may be more difficult to obtain a good history. A lot of times, patients are awake before the seizure, and at times they preserve, because the focal seizure, awareness may be preserved during a seizure. So they can actually tell you a lot of what happens. So some kids can tell you that they feel the fish being pulled. Some they can tell you that they feel like tingling on their face, or they feel like it feels heavy. The family can notice drooling and difficulty speaking. And they can also have tonic-clonic activity, but tonic-clonic activity may not necessarily be present. So especially in young children, this type of seizure may be misdiagnosed with sleep terrors, because kids that cannot maybe articulate very well what they're experiencing, they seem like they're half awake, and they have an odd behavior. They may seem scared because they're drooling. Maybe they're not understanding what's happening. So, but the diagnosis here is beside the history. But with kids, the difficulty is having a good history here. The diagnosis, the key remains the EEG in this type of seizures. So we spoke about the three main seizures, epilepsies related to sleep. And now I'm just going to tell you a few words about the most common non-epileptic events out of sleep. Here we made a table in one of the reviews that we wrote. Fundamentally, you have to think about parasomnias. And I was telling you, parasomnias, it is a disorder. It is a group of disorders recognized and classified in the International Classification of Sleep Disorders. But fundamentally, it's a very descriptive term. And basically, again, it means any abnormal behavior out of sleep or during the transition of wakefulness and sleep, or vice versa. So classically, during a parasomnia, is a patient may seem half awake, half awake, half asleep. So that's usually the most important, the feature that makes you always think is a parasomnia. Then we have sleep-related movement disorders. They're usually most commonly is periodically movement disorders, which are basically movements of the limbs. Usually it's a triple-faction that occurs periodically. So it's not rhythmic, it's not erratic, it's periodic. It's between 5 seconds and 19 seconds between the movements. And because they occur during sleep, and the patient should not be aware of the movements, a lot of times we need to rule out seizures. And the key there is always either a sleep study in which you see like movements very well, and I'll show you in a moment an example, or is the with the EEG and you rule out seizures. Narcolepsy presents fundamentally with daytime symptoms, but there are some sleep events which may be confused with epileptic events. One is a sleep paralysis and hypnagogic or hypnopompic hallucinations. These basically are moments in which a patient feels like they're kind of waking up, their body cannot move, and their brain is very active, and they are seeing things that are not there, usually shadows or people. So this is because they are half awake during REM, and this is actually what happens in REM. In REM, your body is paralyzed and your brain is active, and this is actually what happened to this patient. So if you can have a good history, you may be able to find those. If not, you need to, usually they have a sleep study, and in a sleep study, we can have a full EEG montage. You can also rule out seizures. So then the sleep-related breathing disorders, sometimes some forms of snoring, sleep apnea can be confused with epileptic events. Psychiatric problems like obviously PNES also, but also nocturnal panic attacks. And I actually have a video to show you, and you will see how similar a nocturnal panic attack could be to a seizure. And the rest, like it's more uncommon stuff. So we'll briefly talk about the parasomnias. And I was telling you, parasomnia, it's abnormal behavior during sleep or wakefulness. And we fundamentally distinguish two types of parasomnias: non-REM parasomnias and REM parasomnias. So REM is more common during the second part of the night, and that's where you will see the REM parasomnia. And during the first part of the night, you tend to see the non-REM parasomnias, which are sleep terrors and confusional arousals in children. Sleepwalking presents in children can continue during adulthood. Sleep talking used to be considered a disorder. It's actually not classified as a sleep disorder anymore. It's not considered a disorder any longer. It's considered an expression of disrupted sleep. So sleep talking is not considered pathology. So, but I still have it in there. So, so we will be talking about REM sleep disorder because it's more common in the adult population. And this is an example of a guy. So let's say this is a 70, 80-year-old guy who's sleeping. It's late at night, it's after midnight. And then you see this abrupt movement. The guy is turning and is kicking, and then you will see he's punching. So if you have a sleep recording during the event, you will see this feature in these patients. So the key is you look at the chin, and also you can look at leg movements here. So these are the EMG leads in which you can measure motor activity. So in REM, this is a classic stage of REM, you should have usually you have a low amplitude mixed frequencies EEG, which will be this one. So the EEG actually looks like a wake in REM, an awake EEG, I'm sorry. And the chin tone should be 0. This is because during REM you should have sleep atonia. In these patients, during the sleep study, you will find that the REM atonia persists. Also during the nights in which they don't have the events. So to make a diagnosis, you don't have to see the events, but you have to have the absence of REM atonia. And this is required for the diagnosis because if that type of behavior could be misdiagnosed for seizures, as you can imagine, because if you also remember the first video I showed you, so you'll see that the seizure can be really similar. Semiology seizure can be really similar to a semiology of REM behavior disorder. So a lot of times these patients, they'll have a sleep study before an EEG. But the sleep study, if you find the absence of REM atonia, you can conclude your diagnosis. Otherwise, you should have nocturnal EEG to rule out seizures. But again, the important thing is that you do need to capture the events during the sleep study to make a diagnosis of REM behavior disorder. This was just another video that I had, just because in this one, you can see both the EMG of the chin lead, and these are the two EMG of the legs lead. And at times you can see also this burst of activity on the EMG of the legs. And that could be enough by the criteria to make a diagnosis of REM behavior disorder. Usually we have 3 leads on the chin. The display shows only 1, but you actually can pull up 3 of them. So if you don't see anything on 1, we look on the other 2. And then the big question here in sleep is actually how much abnormality should you see? So the idea is like you should see a difference in amplitude of at least 1/3, and for at least 1/3 of the EMG recording. So that's pretty much what we're looking for here when we look at a sleep study. So here it goes, like, so he's yelling, moving, he's punching. It's very, very similar to the other guy. They both turn and punch. That's why they're very stereotypical, like seizures, and that's why it also can be very difficult to distinguish these two, because they always have the same type of behavior, which is kicking, turning, punching. So we have tried to put together like a summary of, how to distinguish really what kind of features we're looking for in the history of these events to distinguish between a parasomnia and a nocturnal seizure. Probably the most important is the frequency of the events. So remember that during a parasomnia, patient can have 1 or 2 episodes per night, and usually 1 to 4 per month. So they're relatively rare. So someone with REM behavioral disorder or child with the confusional arousal sleep there, they really don't have these events that frequently. So you're thinking about the weekly events. And then when they happen at night, maybe they happen once. But with seizures, especially from the frontal lobe, they really occur in clusters. So you're talking about many seizures in one night and about many seizures in a month, but especially more than 1 episode per night. So frequency is very important. The second is the duration. Seizures are brief. So you expect seizure not to last more than a few minutes. During a parasomnia can be very prolonged. So you're talking about 30 minutes or so. So then if we're looking about what is the feature that the most likely is the most important feature to differentiate the two. So which clinical feature is the most strongly suggestive of parasomnia? It's really the failure to fully wake up after an event of complex behavior. So after a parasomnia, during a parasomnia event, you expect the patient not to be awake or not to be aware at the end of the event. The difference is that with the frontal lobe seizure, after frontal lobe seizure, patient is awake. Usually this is very important because it's really the opposite of what you know from a daytime seizure. So when the seizure occurs in the daytime, you classically know, okay, how do you differentiate syncopal from seizure? You see after a seizure, patient should be drowsy, should be difficult to recover, they should be awake, or if they're fully awake, this is not a seizure. Remember, when things happen at night, it's the opposite. So nocturnal frontal seizure, they occur during sleep, but right after the seizure, the patient is awake. So this is another group that basically tried to develop an algorithm. I don't love algorithms myself when I think about these things, but they can help. So the first, they start with the question, well, does the patient fully wake up at the end of an episode? So if you answer yes, okay, we think more, most likely seizure, as I just told you. Is that discrete offset? So do you see really an offset? Yes. So then you can conclude almost semiologically, just by history, you can highly suspect a seizure. If not, you think about the position of the patient. The patient does not sit up, so they stay down, it's a seizure. If they sit up and they do the stuff, you think more is like a parasomnia. If you did not have a distinct wakefulness after the episode, you have to look basically for dystonia, and dystonia or posturing and versive head movements, like the first video I showed you. That guy, in fact, was a seizure. If you remember the 2 videos, the first guy, the young guy, he had really a posturing which was sustained, while the second one, the older guy with the REM behavior disorder, he had more abrupt movements, more than a posturing. So this is fundamentally, these are the 3 features that you can remember to distinguish about seizures or parasomnia during sleep. Just to be complete, I also wanted to show you this video. This is, let's say, it's a young woman with PTSD, depression, anxiety. So this actually is a panic attack. If you look at only at the semiology, if you look at just what happens, actually the audio is on. You see, she doesn't even say much, and you almost think she has a dystonic posturing. Myself, if you show me the video like that, I could think this is a seizure. She's also spitting. Ictal spitting is very well known as in the semiology of seizures. But this was with a full EEG, this was established that it's a panic attack. In reality, if you have an EEG, obviously the diagnosis becomes very relatively easy. But semiologically, history-wise, the most important thing, there are a few things are actually easy to tease out by history. One is this patients usually they have a profound history of, especially of anxiety and panic attacks. So most of these patients have also panic attacks during the daytime. So that's one thing. Second, patient they wake up and they know they had a panic attack. So most of these patients, they're also aware of the fact that they're having these problems and they have a panic attack. It's almost when a patient has a panic attacks during the daytime, they know what they are and they're able to recognize them themselves. So how, what tools, what do we do to, what can we use to differentiate the two? As I was trying to make you understand is that the history is probably the most important thing. So as always, obviously videos from family member are very important because the semiology of this event, as I was telling you, can really make you distinguish the two. EEG for some of this remains essential. Ambulatory EEG can be important, and obviously inpatient EEG monitoring or the video EEG, the video sleep study, if you can have it with the full extended EEG montage. A lot of times, if, for example, you suspect REM behavior disorder, you will go for the sleep study first. I always try to order to have the one with full EEG. We cannot always have a full EEG on our sleep studies. That's there could be a limitation. And otherwise, you can go for nocturnal EEG. So between all this, you should be able to come up with a diagnosis. So now we're going to switch gear and we're going to talk about sleep disorders in patient with seizures. So before I kind of tell you, I told you how to distinguish and separate the two. And now we're going to see how patients with seizures can actually have sleep disorders. So we know that there is a complex actually interplay between sleep and epilepsy, because clinically we know the seizure can directly disrupt sleep. They disrupt sleep quality, quantity, and sleep architecture. Patients with epilepsy have a poor sleep efficiency and quality, and this is present also in patients that do not have seizures at night and when they don't have seizures at night. This has been very well described by multiple studies. And also there have been tons of studies done on sleep in patients with epilepsy, showing that they have increased awakenings, reduced sleep efficiency, reduced REM, and increased stage changes. On the opposite, sleep can affect seizures, and because sleep fragmentation, sleep deprivation, and hypoxia can promote basically neuronal synchronization. Then sleep deprivation and hypoxia can cause increased neuronal excitability, and in turn can cause promote neuronal synchronization and therefore seizures. So when we talk about sleep disorder in epilepsy, we're talking about sleep breathing disorders, circadian disorders, and insomnia primarily. And we're going to touch a little bit on the three of them, starting with the sleep breathing disorders. So sleeping disorder means obstructive sleep apnea and central sleep apnea. This is a busy slide, and but it's just to show you that they have been multiple studies, mostly retrospective, showing that the patient with epilepsy have a higher prevalence of sleep apnea, not only obstructive sleep apnea, but also central sleep apnea. The difference between the two, obstructive sleep apnea is related to an obstruction of the airway. Central sleep apnea is considered secondary to a decrease in breath drive. In reality, they go together. For who practice sleeps and whoever reads sleep study, we know very well that the patient with obstructive sleep apnea have also central sleep apnea. Not only they have two different types of apneas, but the same apnea, which is called in fact a mixed apnea, can have both central feature and obstructive features. So this is a summary of the studies about showing that basically, regardless of BMI increase, patients with the epilepsy have about 30%, 30% then they may have developed sleep apnea, compared to about 10% of the general population. So why do patients with epilepsy should have sleep apnea? So fundamentally, the idea is that, well, there's tons of medications that these patients take, and they may promote sleep apnea, and they may basically alter the control of breathing control. That's one of the idea. There are tons of reports showing the VNS can cause that. I'll show you a slide in a second. All this research got a lot of attention because of the studies on SUDEP, which is the sudden onset of death in epilepsy patients. But usually occurs at night, and is related to respiratory arrest. And because of that, you know, the idea behind all this is that if this patient may have central sleep apnea, which may occur at night, that is not diagnosed, and then may develop will be prolonged and cause cardiac arrest. So, and I will go into that in a second. Just a few words about VNS, because I think we should know, because there are tons of evidence showing the VNS can cause directly obstructive sleep apnea, because it alters or stimulates the vagus nerve, and so can alter can cause directly alteration of both of the airways and muscles, basically. Fundamentally, that would be the thing. So there are also studies that have shown that patients did not have sleep apnea before VNS, and then develop it afterwards. Although in general, you know, the VNS patients are a small subset of our epilepsy population, but we should be aware of it. So I was telling about the central sleep apnea. So the main question is a central sleep apnea promoting or causing seizures, or a seizure causing central sleep apnea? And there is more evidence supporting the second hypothesis, that seizure may actually promote respiratory arrest, and in turn may cause SUDEP. And this is an EEG. These are intracranial recordings of a patient with temporal lobe epilepsy, in which basically they were able to catch central apnea and to show that seizures from one side. So this guy here, this is the left side. So these are left temporal lobe seizure, which is terminating. Then suddenly you start seeing sharps on this side too, and you see a seizure that starts on the other side. And then the seizure becomes sustained. You get what is called an ictal apnea. So this is a very good example, which shows that during a seizure from temporal lobe, the seizure can bounce to the other side, and it can cause a central apnea. We also looked at central apneas in patients with seizures. We had a cohort of, these things were about 400 patients, in which we look about older sleep studies, and we saw that about 10% of these patients had central so the main, why is this so important? Beside the idea of SUDAP, is like, so if patient with seizure have more sleep apnea, okay, do we need to treat them? Shall we need to treat them? Do we need to treat them with CPAP? It's important for them to treat CPAP. So initially, this was years back. There were tons of these small reports showing that patients with the CPAP and seizure were doing better than the others, i.e. that CPAP could also provide a better seizure control. And after that, we did one study. This is with an old study now done in BU. Was a retrospective study, but basically we were able to find that there were no reduction in seizure frequency after the use of CPAP, but there were a higher chance of patients that were seizure free. And these are mostly patients with obviously a relatively low frequency of seizures. But basically the difference was that basically using CPAP, the risk of becoming seizure free was 1.5 times higher than those without using CPAP. And then this has been done, but you see, the major limitation of our study is that we did not control medication. So we didn't know if there were like medication changes during the use, before or after the use of CPAP. But this was done after by this group, which redid the study prospectively, and they looked at patients that were using CPAP and those that were not using CPAP, and they were able to show that there were not a higher percentage of patients with seizure freedom, but there was a seizure frequency reduction. So results were not, they were in line with ours, was different, but in line with ours, but still were showing a benefit of use of CPAP on these patients. So how should we screen and what should we do for these patients? When we see seizure patients in our clinic now, we all ask if they are sleeping during the daytime, and if we need an objective measure for sleepiness, we use the Epworth Sleepiness Scale. We have it integrated in our medical record system together with the Stop Bank questionnaire. This actually is mostly important for insurance to have a reason to order a sleep study if we need an objective documentation of data sleepiness, even regardless of BMI. So we can basically ask obtain a sleep study on a seizure patient. It's very simple to do an Epworth scale. It really takes 1 minute. At least it's in there, and with that you basically can have a sleep study for these patients. So now, these are the sleep breathing disorders. We can talk, the other was insomnia. Insomnia is very prevalent in patients with seizures. Patients with seizure can have sleep onset insomnia and also sleep maintenance insomnia. We know that insomnia is highly prevalent in depression and anxiety, and we know that depression and anxiety is highly prevalent in epilepsy. So most likely the intercept between those is most likely like that. The most important thing we have to, when we treat patients with epilepsy and they have insomnia, is looking at what medication we're giving them. There are some medications that they can cause insomnia. One is lamotrigine, classically, and we sometimes give a dose at night. Felbamate, there are many reports, and we know practically that can cause insomnia, and also Keppra. So be aware of the use of this medication and the fact that they can cause insomnia. SSRI can also cause periodically movement disorders, and they can disrupt sleep. I had one slide here just to show about what periodically movements are. Remember, a lot of your patients with seizure are on SSRIs, and they may have periodically movement disorder. We actually have shown this in children taking SSRIs, showing that they're having more like movements. The third, beside insomnia and the other group of sleep disorders, is the whole circadian sleep disorders, so circadian rhythms. So and fundamentally, circadian means day and night, not sleep or awake. We always have been known that there is a daily periodicity in seizure. This was established many years ago. And also initially when seizures were classified diurnal, nocturnal, or diffuse. But do seizures really have a circadian pattern? So there are a few studies that have been trying to answer this, and I was part of one that was published in Neurology, in which basically we looked at about 1,000 seizures, and we looked if they were out of wakefulness, of sleep, at what time of the day, and if they were, and then we looked at semiology, seizure localization, and then fundamentally we found that some seizures were more common in sleep, some were common in wakefulness. For example, hypermotor seizure, automotor, more common out of sleep, and hypomotor, so tonic seizures, myoclonic seizure, more common during wakefulness. Some were common during the night, and some were common during the day, like myoclonic and hypomotor during the daytime, and hypermotor and automotor during the nighttime. Here, if we're looking at distribution of this seizure across the time of the day, we could see that the hypermotor seizures, like here, they are more common during wakefulness, during sleep, and during the first part of the night, similar to automotor seizures, which are here, and some of the tonic seizures. But on atonic seizure, they're more common during the midday and out of wakefulness, and similar to myoclonic seizure, which could really see they were common in the morning. In reality, when we run through this statistical analysis and we try to answer the question, like, is wakefulness and sleep a better predictor than day or night for semiology? And the answer is that wakefulness and sleep is more important. And the whole field of seizure and circadian rhythms, there's been a shift on this. So we don't talk anymore about nocturnal seizure, daytime seizure. We try to talk about a seizure out of sleep or out of wakefulness, because it makes a difference when we're talking about semiology of seizures and also seizure localization. This is just about the distinguish between a general seizure and a seizure from a different area of the brain, in which we have found that most general seizure was during the morning. This is another study in which we looked only at idiopathic generalized epilepsy and seen that most of the seizures were out of wakefulness, which in clinical practice you also know. Because again, even GNI that has seizure at night, remember, there are night, but they're out of wakefulness. And this is just a shorter study in which we looked at the lesional epilepsy. And the only exception here is that seizure from the temporal lobe were more common during the daytime. This is really a short study, and the statistical power was very low. So why is this important? And basically I can conclude in a moment, is because if you know that the seizure can occur at a different time of the day, or out of sleep, most likely, or out of wakefulness, you can change the schedule of medication. And in these studies, we showed that it was done prospectively in children, that especially with the kids with nocturnal seizures or with BACs, which also occur at night, if you basically give them more medication at night, they do much better, and you provide a better control. And another thing here, this is just the last thing I wanted to show. Some patients may have, you can look at just the sleep of some patients. For example, this is just a case which is super interesting, a kid with JME. It presents with seizures usually at night in the morning. And then when we obtained this sleep diary, we found that he had a delayed sleep wave disorder, which is basically just a pure shift in the sleep period. So these are kids that cannot fall asleep before midnight, and they always go to sleep about 2, 3 a.m. If you can correct that, you may provide a better seizure control. And this is what we show with this kid. We were able to correct his sleep period, which is very difficult to do. You can do it only if someone is very diligent in the sleep scheduling. We use the melatonin, but you have to do really time and melatonin. It has to be taken a specific time of the night. So we were able to do this with this kid only because of the family. It's not easy to obtain these results, but we really had a better seizure control on him. He was on Keppra as well, but I think it's really remarkable how you can recognize a sleep disorder or a sleep pattern and fix it and make seizure better. While I'm sure in clinical practice you tend not to ask about sleep, or definitely you don't ask about when you go to sleep and when you wake up. So here I can conclude. So obviously, I hope I can I could transmit that I think identifying sleep disorder and epilepsy is important because one can help the other. And if you can remember that the sleep wakefulness in the end is more important than daytime and nighttime in recognizing the different types of seizures and epilepsies. So,
Vendrame, thank you very much. Great talk, and actually, it's definitely the topic that is gaining more and more interest. The sleep and how influence our electrical activity of the brain, etc. We have several questions for you.
Yeah.
Is there a role for the surgical management of sleep-related epilepsy disorders similar to the other forms of drug-resistant epilepsy?
I'm sorry, can you say that?
Is there a role for the surgical management of sleep-related epilepsy disorders similar to the other forms of drug-resistant epilepsy? Is there a role for a surgical treatment of these epilepsies, of certain epilepsies you discussed?
Yeah, I don't think it would be any different than any other type of treatment. As far as the evaluation, the importance of the whole semiology study was because if you in non-lesional epilepsies, knowing what type of semiology. And so knowing if a seizure out of sleep or out of wakefulness could point to the correct localization. So if you can, so semiology is important because you can localize, so it becomes very important when you have a non-localizing, you don't have a lesion and you have difficulty in localizing through an EEG. So if you can use this, the sleep stage for knowing that was the whole purpose of the whole idea of the semiology study, to understand, to point to a better semiology, then will guide you to a better localization. So the most important is in the known for the non-lesional epilepsies. So that was the question.
The sleep itself, it's a known, the sleep deprivation or lack of sleep is a known risk factor that lowers seizure threshold. And in somebody who have epilepsy, it doesn't matter, whether it's frontal lobe, temporal lobe, et cetera, that can
exactly.
Do we know the mechanism, how the sleep deprivation actually, how does it work? Why does it lower seizure threshold?
But fundamentally, because when you have sleep deprivation, in the you get in any type of sleep stage, during the sleep time, you will have less REM, more stage 2, and seizure come during this stage 2, and some of the stage 3, but fundamentally stage 2. So stage 2 and drowsiness. So the stage when your brain stays, and at the beginning of stage 1, at the beginning of sleep, and some of the stage 2, you will have more seizures. So, and in fact, this has been shown also with the higher frequencies of interictal abnormalities. Though they have shown that the patient that are sleep deprived during routine day EEGs, they go into drowsiness, they transit into the stage 1, and they fall asleep into stage 2, and that's how they have more interictal abnormalities. So fundamentally, is because there is an alteration in the sleep architecture. Yeah.
Okay. Go ahead. I'm sorry.
Yeah. So that's fundamentally it's secondary to an alteration in sleep architecture. More than anything else. In fact, even the idea of the hypoxia has been criticized, because not all patients with sleep apnea are hypoxic, and hypoxia directly may not cause neuronal excitability or synchronization, which intuitively that you would think that is what happens, Because the idea is like sleep apnea also causes sleep deprivation, right? Because you're not really sleeping the amount of time your brain is not sleeping, So the idea in the end is like sleep deprivation causes alteration of the sleep architecture.
No, you touched on that a little bit during your talk, but can you elaborate a little bit more of the secondary causes for parasomnias and REM sleep behavior disorder, like medications, alcohol, or some other factors that can?
Yeah. So probably I think you're referring mostly to REM behavior disorder, right? Yeah. So REM behavior disorder. Number one, we have to think about usually male patients, could be female or male, above age 50. Could be a healthy person, no other risk factors. Number one thing we always have to look for is SSRIs, because SSRI can directly cause REM behavior disorder. So, and we have seen in clinical practice, it must have happened to you too. You see these patients, you just remove the SSRI, you switch into a different medication, and they'll do better. For example, even if you have them, you find them on Paxil or a Prozac, you can switch into Wellbutrin. Bupropion is a much better medication for because and you can give you actually give them during the daytime, because otherwise it can cause wakefulness. And another bad one that you really have to always eliminate is Remeron, which is a mirtazapine, which is awful. But I mean, I see patients with in my clinic all the time, and it's very simple for me to fix that, because SSRI because number two, it is common with the alcohol, usually as alcohol withdrawal more than alcohol consumption. And so we say, but usually those are temporary, so you see them. So it's kind of like, unless you can deal with alcoholics that they have constant withdrawal, usually it's by history, that's usually, it's, you can distinguish the two, or like find that it's alcohol withdrawal for that. Then obviously we know the REM behavior disorder is associated with Parkinson's disease and with Lewy body dementia. Emerging research there showing higher prevalence. What I always say tell patients, and it's 70% chance to develop Parkinson's disease within 12 years. Apparently, regardless of the age of the person that comes to see you. So what we do, we always screen for Parkinson. If there's no Parkinson feature on the exam, we just follow the patient. If there is one Parkinson feature, like could be just a tremor or something else that can point to suspect Parkinson, we obtain, anyway, we're not sure about it. Let's say, not conclusive, but your guy with REM behavior disorder, you think he's telling you, I have a tremor, doesn't have it on exam, you don't have cognitive rigidity, so you really don't know what you're dealing with. We go for that scan now, because it's easy to get them approved, and so that's how we do. And then we don't do anything else. We just follow patient. But we always talk about that, and now patients, they really, because they read about Lewy body dementia, but they always think, oh, I'm gonna have a dementia, gonna have Alzheimer's. That's the classic question they ask me. So I try to clarify that we're talking about more the Parkinson spectrum and Lewy body when I talk to them. I don't know if you have a different approach, but and I explain that we follow them basically, and then we explain that we look at the exam and the history, of course, and then I go for the DAT scan if I'm not sure that I'm not dealing with Parkinson.
I think I'm gonna we're past time, but I'm gonna one more question. You mentioned that genetic frontal lobe seizures respond very well to zonagran.
Yeah.
Is this your number one medication right now, or because usually frontal lobe seizures people go for Depakote, Keppras, etc.
Yeah.
Is the zonagran your number one medication right now?
It's really this is actually not my experience. This is published. But for me, it's only when I have the genetic one. Otherwise, unfortunately, I always go for Keppra. So yeah, so is either levetiracetam or then lacosamide. These are the big ones. Then obviously, if I've also used carbazepine a lot, can really work. Unfortunately, a lot of times they come to us, they're already on levetiracetam. So if you have to choose a second agent, then I usually do oxcarbazepine. I've done lamotrigine. And if I can, I do zonagram because it's also a one-time dose, so it becomes very easy, and you can take it. They can take it at night, so it's easy and can really work. But theoretically, the evidence is about the genetic form. Remember, so the autosomal dominant. But I think it's a good it's a good thing to remember, because I think we tend to forget about zonagram.
Mm-hmm. Right, it's definitely not on the radar immediately.
Yeah, exactly. But I think because usually, if you go on highest dose, they can cause kidney stones. In reality, it's like topiramate. How much time you use topiramate in clinic? How many kidney stones do you see? It's only when you go on high dose of topiramate that you really see. If you think about how much topiramate we prescribe, and right, it's not that you would not do topiramate because of kidney stones. So unless someone has a history of kidney stones or disorder but predisposed to kidney stones, I comfortably do zonagran at night, one time. Yeah.
Dr. Vendrame, thank you very much. It was an excellent talk. Thank you everybody for joining, and we hope to see you back in 2 weeks.
Thank you so much. Thank you for your. Bye-bye. Thank you.